Dear colleagues, I'm Dr. Taner Yılmaz from Hacettepe University Hospital, Ankara, Turkey. I'd like to talk to you about sulcus vocalis today. Sulcus vocalis is usually a congenital problem. Much less frequently, it may be acquired due to vocal trauma. Its treatment usually starts with voice therapy. If the voice therapy is not successful, we have to perform surgery on these patients. In the future, we will be talking about more on use of growth factors, stem cells, and gene therapy for sulcus vocalis. The surgery can be an indirect surgery or direct surgery or combination of these two. Indirect surgery, meaning that you are addressing a glottal closure problem via medialization. People with sulcus vocalis have a glottal closure defect, and through that glottal closure defect, there is air leak during speaking. And this needs to be corrected either with injection laryngoplasty, injection of filling materials to both vocal folds, or thyroplasty type 1, unilaterally or bilaterally. Another indirect solution to a problem is high-pitched voice, especially males with sulcus vocalis have high-pitched voice, and they want it to be corrected. Direct surgery involves treatment of superficial lamina propria, which is deficient in sulcus vocalis patients. Here, we want to improve the vocal fold mucosal wave. It can be done with incisional undermining to elevate, you incise sulcus and elevate sulcus and leave it. Incise sulcus, elevate it, undermining, or put grafts into it, like fat, fascia, collagen, gelatin, and many others. Or you can incise it, elevate it, and do vertical incisions in order to cut the stiffness of sulcus vocalis, vertical incisions as described by Dr. Pontes from Brazil. You can excise sulcus and leave it. You can excise sulcus and close the defect with primary suture. Or you can excise sulcus and you can use local flaps to close the defect. Recently, there is angiolytic laser use for treatment of sulcus vocalis. PDL, KTP, and diode lasers are used for this purpose. Or you can inject steroids or to decrease stiffness on vocal folds. Or you inject regenerative biomaterials such as fibroblast growth factor, hepatocyte growth factor, or platelet-rich plasma to improve mucosal wave formation in sulcus vocalis. Or you can combine these indirect and direct treatments, which is usually the case. This combined treatment is usually chosen for treatment of sulcus vocalis. When you do a PubMed search for sulcus vocalis, you will end up with 106 articles. That means about less than 2 manuscripts per year. If you do PubMed search for vocal fold paralysis, you will end up 3,600 manuscripts. So there are so few studies on sulcus vocalis. And if you read those studies, in many of them, you will see that sulcus is studied together with scar and vocal fold atrophy. These are totally unrelated things. Sulcus vocalis is different from scar and also different from atrophy. But they are grouped together in order to increase the number of patients in this study. And also type 2 sulcus and type 3 sulcus are studied together in the same study. However, these are also totally different things. Inflammation and para and hyperkeratosis is a characteristic of type 3 sulcus, not type 2. Whereas epithelial atrophy and absent superficial laminopropria is a characteristic of type 2, not type 3 sulcus vocalis. So these are totally different things, and they should not be studied together in the same study. Type 1 sulcus vocalis is a physiologic sulcus vocalis. It's usually seen, for example, in patients with vocal fold paralysis, paralyzed vocal fold. Looks like as if it's having a sulcus vocalis. In reality, it does not have it. Or a contralateral polyp, for example, hitting the ipsilateral vocal fold may give the appearance of sulcus vocalis or atrophic vocal fold on ipsilateral vocal fold. If you remove that lesion from contralateral vocal fold, ipsilateral vocal fold appearance will convert to normal in a short time. Type 2 sulcus vocalis is also called sulcus vergeture. It is characterized by vocal fold mucosal atrophy or epithelial atrophy. Here it shows it comes down to the vocal ligament, but you will also see that it may go down to the vocalis muscle as well. Type 3 sulcus vocalis is spontaneous drainage of the vocal fold cyst, epidermoid cyst or retention cyst of the vocal fold. It drains spontaneously, and there will be a pit formation on the medial surface of the vocal fold. It is usually located within this superficial lamina propria, usually does not penetrate deep in the tissues. Whereas here it's shown as if type 3 is penetrating down to the vocalis muscle, which is not the case in my own practice. As for the treatment options, here is the incision, undermining. Incision undermining and vertical incisions of unequal length are done, as described by Dr. Pontes from Brazil. That also gives good results. This cuts the scar of sulcus vocalis and releases the scar of stiffness of sulcus vocalis. Here is the treatment of type 3 sulcus, a pit. It's incised, dissected, removed, and sutured. Recently, colleagues from South Korea studied angiolytic lasers for the treatment of sulcus vocalis, and they said by applying angiolytic lasers to people with sulcus vocalis, there will be improvement of mucosal wave formation and glottal closure. Another similar study using PDL for the treatment of sulcus vocalis. Here, PDL application, because it's angiolytic, it preserves epithelium here. It attacks the vessels in the superficial lamina propria. They say that there will be collagen realignment and new collagen formation with the application of angiolytic laser, and there will be new superficial lamina propria formation as advocated by our colleagues from South Korea. These are the pictures shown in their manuscripts. They say mucosal wave improves and glottal closure improves. I've been doing excision and primary suturing of sulcus vocalis plus medialization laryngoplasty. I published my experience on 44 cases in European archives in 2012. Patient selection is very important to keep the patient satisfaction level high. You need to select patients, not operate on every patient you see. The socioeconomic level or the education level of the patient is important because he has to understand his voice problem, possible results of surgery. He must be able to differentiate between the voice before surgery and voice after surgery. If he can't differentiate this difference in voice, then the patient will say, nothing has changed in my voice. So you as a surgeon will be unhappy due to this response of your patients. You will aim to improve voice and never promise good and excellent quality of voice. You never promise normal voice. We will improve intensity of voice. I suggest you not to operate on accidentally discovered sulci because you do not know how the results may be. High-pitched voice is still a big problem. And you need to do repeated injections because the filling materials dissolve away in time. Or if you don't want to do injections, you can do type 1 thyroplasty, uni or bilaterally. I studied these patients between 2005 and 2010, 44 patients, usually females, and these are young patients, all had sulcus type 2. Preoperatively, before surgery, everyone received voice therapy. Those who were not satisfied with voice therapy were operated. We did pre-op exams and repeated them 1 year after surgery. The minimum follow-up is 1 year and mean follow-up is around 30 months. We performed video laryngostroboscopy. On this stroboscopy, we evaluated glottal closure on a scale of 5, evaluated mucosal wave amplitude on a scale of 4, symmetry of mucosal wave on a scale of 4, and periodicity of the mucosal wave, again, on a scale of 4. Voice handicap index 30 was performed before and after surgery. Aerodynamic analysis, including maximum phonation time, mean flow rate, mean resistance, mean power, mean efficiency, and mean subglottal pressure were measured. Acoustic analysis with continuous ah and constant phrase was done. And we evaluated fundamental frequency and speaking fundamental frequency, jitter, shimmer, and noise to harmonic ratio. Here's a picture of a patient with type 2 sulcus vocalis, left side, on the right side. The left side was excised. We directly ended up in vocalis muscle. There was no vocal ligament on it. There will be a poor prognosis after surgery because there won't be a mucosal wave formation, most probably on the left vocal fold. Whereas on the right side, there is vocal ligament, and there is a possibility of mucosal wave formation on the right side. I sutured the defect with Vicryl 6O sutures and closed the defect. I operated on the same patient for some other reason, and during that surgery, I took a look at his vocal folds. You see, sulci are gone. However, the sulci were replaced by the scar tissue of sulcus surgery. As you see, there is no vocal ligament on the left vocal fold. However, vocal ligament is present on the right side. Another patient with atrophic free edges of both vocal folds and on the anterior half of the vocal folds. You see there is mucosal atrophy and the shallow sulcus on the left one, on the left vocal fold. Vocal fold atrophy on the free edge of the right vocal fold. So I excised them and then sutured them and performed type 1 thyroplasty bilaterally during the same session. This is the view from inside, how the vocal folds got together after thyroplasty type 1 bilateral. As for the voice handicap index results, all parameters improved significantly after surgery. Moderate to severe voice handicap became mild voice handicap after surgery. As for the grade of dysphonia, grade, roughness, and breathiness improved significantly after surgery, whereas asthenia and strain did not change. Stroboscopy results, glottic closure improved significantly, amplitude improved significantly. However, symmetry and periodicity did not change significantly after sulcus surgery. As for the aerodynamic measures, maximum phonation time improved significantly, mean airflow rate improved significantly, mean efficiency improved significantly, and mean subglottal pressure also improved significantly. However, mean resistance and mean power did not change significantly after surgery. As for the Acoustic analysis results. Fundamental frequency and speaking fundamental frequency did not change significantly after surgery. Jitter, shimmer, and noise harmonic ratio improved significantly after sulcus surgery. As for the conclusion, if the sulcus is short, narrow, and shallow, then the post-op voice result will most probably be much better than before surgery. However, if it is long, wide, and deep, then the post-operative result will not be that good. Usually, treatment is not satisfactory enough, and most patients are not satisfied with the post-operative voice result usually. There is no gold standard treatment. Excision and primary closure with sutures is one of the treatment options. If you select patients well, then you may increase the percentage of happy patients. If you operate on everybody, then this percentage drops significantly. Injection materials is a significant problem. High-pitched voice continues to be a big problem as well. A lady with bilateral sulci and asymmetric mucosal wave formation together with glottal gap is seen in this stroboscopy video. This is her stroboscopy after surgery. You see glottal closure improved. The symmetry of mucosal wave formation improved significantly compared to pre-op stroboscopy. Intraoperative video of one patient with atrophic vocal folds anteriorly, bilaterally, type 2, shallow and short sulci. I grasp the epithelium, the vocal fold, and I will incise and then excise the epithelium. Only the epithelium is removed. I'm paying attention not to enter vocal ligament to decrease scar formation. The right side was done. Now the left side. Again, I grasp the free edge of the vocal fold. Right now, I entered the vocal ligament. Then I realized that I got more superficial and removed the epithelium only and did not harm the vocal ligament any further. And then I sutured the defects with 6-0 Weichel sutures. Usually 2 on each side is enough. Then I will be doing idealization laryngoplasty. Here it's calcium hydroxylapatite.
Jeoloji mühendisiyim.
Young man, an engineer,
mühendisi olarak çalışıyorum. Navak'ta oturuyorum.
hoarse
32 yaşındayım.
voice, breathy voice.
Nasıl bir ses sorunu yaşıyoruz?
Ses sorunu uzun süreli
He's
konuştuğum
getting
zaman
tired after speaking. His voice after surgery, 1 year after surgery, intensity improved, breathiness decreased.
Ses kısıklığı, konuşurken konuşma zorluğu, güçlü hastalığı nedeniyle başvurdum.
A young lady with bilateral type 2 sulci, you see the atrophic borders, free borders of both vocal folds. She's having muscle tension to improve phonation and glottal closure. So during phonation, we are unable to see the vocal folds. And voice quality is really poor. She received voice therapy, but did not get any benefit. Grade 3 dysphonia, very bad voice, breathy voice.
Tam 30 yaşındayım.
İktisat işletme mezunuyum.
Quality improved,
Geçen sene Mayıs
maybe grade 1
Mayıs
dysphonia, maybe grade 0,
beni
less redness.
bu zamandan bu yana neler değişti? Çok şey değişti. Bir kere
A happy patient.
sesimi
Not all patients have such good voices. You see the stroboscopy, muscle tension decreased, so we are able to see mucosal wave formation, glottal closure improved, and there is mucosal wave formation. A young male with dysphonia and with glottal closure defect, I was unable to see anything but a nodule, possibly a cyst formation. You can see mucosal wave formation, but it's irregular, and some vocal fold edema, and poor closure as well. Intraoperatively, well, there is no nodule, there is no cyst either. Well, you see, there is type 3 sulcus here, type 3 sulcus. I removed that type 3 sulcus, another type 3 sulcus on the right vocal fold as well. So this is an unexpected finding. I removed the lining of type 3 sulcus, so vocal ligament is intact, as you see. Vocal ligament is intact on the right side as well. So I close the defects with sutures. Postoperatively, there is decrease in fundamental frequency, much regular mucosal wave formation, better glottic closure, and better mucosal wave formation.
15 yaşındayım. İnönü Anadolu Lisesi'nde okuyorum.
1 year
Ee,
after his surgery,
Sesim kısıktı, o yüzden buraya başvurduk. Babam ayakkabıcı, annem ev hanımı. Kayserliyim.
thank you for your attention.